Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Type 2 reaction, also known as Erythema Nodosum Leprosum. This name Erythema Nodosum Leprosum is given by Japanese leprologist Murata after studying histological features and clinical features. He found it is similar to Erythema nodosum, but it is not Erythema nodosum, occurring in only leprosy patients. So he named it Erythema Nodosum Leprosum, seen exclusively in multibacillary patients, mainly in leprosy, lepromatous leprosy spectrum, and borderline lepromatous. Coming to epidemiology, before pre-sulfone era, in 50% of LL cases and 25% of BL cases, incidence of reactions occurred. After introduction of MDT, it reduced it to 15% in LL and 4% in BL cases. Most commonly occurs around 6 months of starting treatment. In my previous video, I already explained you reactions can occur during treatment, before treatment, or after treatment. Why? Even after treatment, dead bacilli will remain in the body for years together until they are eliminated from the body. Can occur before treatment as a presenting feature. In leprosy patients, they may present with us with painful nodules, Erythema nodosum leprosum, in up to 1/3 of the patients. It may be the presenting feature. So it can occur before treatment in 1/3 of the patients. Can occur even after treatments up to 7 to 8 years. I already told you it takes years together to completely eliminate the bacteria because of persistence of antigens. Granular or fragmented bacilli represent dead bacilli. Reactions in response to antigens from dead bacilli are more severe than live bacillary antigens. Coming to risk factors or precipitating factors. Risk factor nothing but multibacillary LL spectrum. Bacterial index being more than or equal to 4, less than 40 years of age. Young patients will have better immunity. This reaction is nothing but an immunological inflammatory reaction. Co-infections like HIV, TB. Co-infection means two diseases occurring simultaneously, one disease influencing the other, like worsening the other disease. Like in HIV and TB, immunity reduces and the other disease may worsen. Hepatitis B, C, typhoid. Intercurrent infection means already patient have one disease and in between another disease can occur, leading to worsening the disease or leading to complications like in leprosy reactions. Intestinal parasites, viral infection, streptococcal infection, filariasis and malaria, nothing but parasitic infestation. Pregnancy and lactation, vaccination, ingestion of potassium iodide, psychological stress, trauma, surgical intervention, strongly positive Mantoux test, multi-drug therapy. In these conditions, immunity increases. Strongly positive Mantoux indicates strong immunity, reduction in complement C4 and increase in antibodies against leprosy. In all these conditions, these are all triggers or risk factors for type 2 reaction. Coming to immunopathogenesis of type 2 reaction, mediated by T helper 1 and T helper 17 cells. These cells will increase in type 2 reaction with reduction in T regulatory cells. Because of reduction in these T regulatory cells, there will be an unregulated T cell mediated immunity in conjunction, in addition with B cells, which produce antibodies against lepra bacilli antigens, leading to formation of immune complexes. Type 3 hypersensitivity reaction with important role of neutrophils. Neutrophils are hallmark feature in histopathology of type 2 reaction. Coming to clinical features, reactions are the major cause of morbidity related to leprosy. Compared to leprosy, which is slowly damaging the body, reactions are sudden in onset and acutely damages because of inflammatory reaction in the body. So prompt diagnosis and timely management is necessary to prevent permanent disability. Type 2 reactions can cause inflammation in any organ invaded by lepra bacilli. In all the organs which is invaded by lepra bacilli, this type 2 reaction can cause inflammation there. Cutaneous lesions known as Erythema Nodosum Leprosum presents as crops of erythematous papules and nodules. Crops means multiple lesions occurring at a time, which are warm, tender, means painful, and blanchable, usually involving face, arms, thighs, palms, soles, can occur anywhere in the body. May be superficial or deep. In severe reactions, it will be deep, having a bilaterally symmetrical predilection. I already told you, can occur anywhere in the body except hairy scalp, axilla, groin, perineum. Why these areas are spared? Because these areas are warmer regions of skin which are spared by leprosy as well as ENL. I already told you, lepra bacilli prefers warmer areas. Lesions fade within 3 to 4 days. Comes as fast as it comes and goes as same, with post-inflammatory hyperpigmentation and desquamation, bruise-like pigmentation or contusion, and scaling, desquamation. Onset of crops of ENL and intermittent fever usually seen in the evening around 5 to 6 pm when the endogenous cortisol is at its nadir. Nadir means the lowest point. Around evening time, cortisol will be lowest levels in the body, so fever and these crops may erupt at that time, because the reason is cortisol is stress hormone which is anti-inflammatory, controls interleukin 6. At evening it will be at lowest point, so inflammation will be appreciated at evening times more. Coming to difference between nodosum and nodosum leprosum. Here it resolves in 3 to 6 weeks, takes more time to resolve. ENL is evanescent like arterial lesions. E for ENL, E for evanescent, short living. Within 3 to 4 days it will resolve with scaling and desquamation. Here it occurs only in the lower legs, usually over shin of tibia. Here it is multiple crops of lesions, more widespread beyond legs. Erythema nodosum is type 4 hypersensitivity reaction. ENL is type 3 hypersensitivity reaction. Immune complexes are formed. Here systemic symptoms are usually mild. In Erythema nodosum leprosum it is prominent. Whichever the organ is invaded by lepra bacilli, their inflammation occurs due to ENL. Erythema nodosum is non-blanchable. Here it is blanchable even with slight pressure with the finger. If we press the lesion with finger with the slightest pressure, erythema will subside, and after releasing the pressure, erythema will reappear. This is nothing but blanchable. Seen in many cases, inflammatory bowel disease, sarcoidosis, TB, streptococcal infection, many causes are there in erythema nodosum. But in erythema nodosum leprosum, in name itself it's there, occurs only in leprosy patients, mainly lepromatous leprosy patients, rarely borderline leprosy patients. In severe reactions, skin lesions may become vesiculobullous, ulcerated, pustular, hemorrhagic, necrotic, erythema multiforme or sweet syndrome like lesions. These severe reactions is also known as erythema nodosum necroticans. In recurrent lesions, chronic panniculitis may develop, because in recurrent lesions, complete resolution of lesions may not occur. There will be chronic inflammation leading to chronic panniculitis, developing to fibrosis and immobilization, called reaction face, hand, foot. Remember, in type 2 reaction there will be peripheral edema, means edema in face, hand and foot. Because of chronic inflammation, chronic panniculitis will occur, leading to fibrosis and forming this reaction face, hand, foot. What are the features of this reaction phase and foot? We will see in detail in future in class of deformities of leprosy. Here this tissue is poorly vascular, usually easily ulcerates with slight trauma, and any wounds on this tissue which is poorly vascular will be poor to heal. Coming to systemic features, here there will be a generalized severe systemic illness. Compared to type 1 reaction, usually systemic illness will be mild there. Here severe. Mainly patients complained pain more than fever. Edema, nothing but peripheral edema on face, hand and foot. Where pain is appreciated, majorly skin, apart from skin, bones, because of periostitis. Joints, there will be polyarthritis and polyarthralgia, painful joints. Digits, inflammation of digits, nothing but dactylitis, leading to painful fingers, toes, digits. Muscle, remember myalgia and myositis. Remember like this, whichever organ is round, there will be pain in type 2 reaction. Eyes round, leading to iritis and iridocyclitis, painful eyes. Remember painful red eyes, fever, cutaneous nodules eruption. Suspect type 2 reaction. Testis, epididymoarchitis, lymph nodes. Generalized tender lymphadenopathy will be there, mostly majority femoral. Nerves and bones, remember like this in cross section, these both also will be round. Neuritis is the most common extracutaneous manifestation, often milder than in type 1 reaction. Systemic features, type 2 reaction is more. Neuritis in type 1 reaction is severe. In type 1 reaction it's severe. Hepatosplenomegaly, these organs also will be tender hepatosplenomegaly. Kidneys are also affected, leading because of glomerulonephritis, acute tubulointerstitial nephritis, because of immune complex deposition, and amyloidosis, which may lead to ultimately chronic kidney disease. Because of this involvement of kidney, there will be proteinuria and hematuria, loss of proteins through urine. Enlist Erythema Nodosum Severity Score, EESS. Based on all these features except architis and some other, we will calculate a score which, if it is less than or equal to 8, we will classify it as mild. More than 8 means 9, 10, we will classify severe. Only two classification, mild or severe, that's it. Coming to Ehrlich's test. E for Ehrlich's test, E for excruciating pain on squeezing above wrist. Rayleigh's test, burning pain on sole when stroked with a blunt object with light pressure. Even with light pressure, if we stroke the sole of the patient with blunt object, patient will suffer with burning pain. This is nothing but Rayleigh's test. These two tests will be useful in screening and deciding the duration of treatment to be given in type 2 reaction. Remember, Ehrlich's test, Rayleigh's test, two tests in type 2 reaction. Coming to investigations, all routines, slit skin smear, we will appreciate majority mainly fragmented or granular bacilli, punch biopsy, increase in ESR or CRP, eye examination, stool examination, bone density monitoring should also be done. There will be normocytic normochromic anemia, polymorphonuclear leukocytosis because of inflammation. Coming to management, main aim is to control inflammation and neuritis. If we are not controlling by giving drugs, in long term it will lead to permanent nerve damage. So to avoid permanent disability, we have to start immediately treatment. If patient is taking MDT, they have to continue as it is. For mild cases, we will give analgesics, aspirin, acetaminophen, diclofenac, tramadol, ibuprofen, indomethacin. If not reducing or worsening or score is increasing more than 8, then we will reclassify it as severe ENL and we will start steroids which have rapid and defined therapeutic action. Oral prednisolone, IV dexa or methylprednisolone pulse. Prednisolone dosage 1 to 1.5 mg per kg for 2 to 4 weeks, almost for a month. WHO says to start with a low dose of 30 to 40 mg. If reactions are not controlled, then we can increase the dosage. After that, we have to taper 10 mg every 2 weeks until 20 mg is reached. After reaching 20 mg, you have to reduce only 5 mg for every 2 weeks. Steroid should be given in a single morning dose coinciding with endogenous cortisol peak. I already told you cortisol controls inflammation by controlling interleukin 6. So early morning time both cortisol and our steroids will effectively controls the inflammation. Coming to adverse effects, acne, gastritis, so we will give proton pump inhibitors, glucose intolerance, hypertension, exogenous Cushing syndrome in long-term cases, cataract, osteoporosis, so we have to do bone density monitoring, increased risk of opportunistic infections. Alternative drugs should be considered in recurrent, chronic, steroid dependent, steroid non-responder and patients having serious comorbidities. Main alternative is immunomodulatory drug thalidomide, 100 to 400 mg per day. Here also WHO says to start with low dose 100 mg. If not controlling, we can increase the dose, taper slowly 50 mg every 2 to 4 weeks, maintenance at 50 mg daily or alternative days. Adverse effects, thalidomide has serious adverse effects like irreversible peripheral neuropathy, sedation, phocomelia. It is actually a sedative hypnotic. Teratogen, increased risk of thrombosis if given along with steroids. Constipation. Other immunomodulatory drugs, cyclosporin A, azathioprine, methotrexate, pentoxifilin. Antibacterial with anti-inflammatory properties, clofazimine, minocycline. Coming to dosage of clofazimine, 300 mg for 1 month. Then taper by 100 mg. 200 mg for 3 to 6 months. Then taper by 100 mg. We will maintain on 100 mg until symptoms resolve. If once the symptoms gone, we can stop clofazimine. Anti-inflammatory, chloroquine, colchicine, antimonials. Other drugs like oral zinc, mycobacterium indicus, pranay, MIP, vaccine, infliximab and etanercept, biologicals. These are all the drugs we will give in type 2 reaction. Coming to case definitions. What is a new ENL? The definition is the reoccurrence of ENL for the first time in LL patients. Recurrent ENL, second episode or subsequent episode of ENL occurring 28 days or more after stopping treatment. After controlling, we will stop the treatment. After stopping treatment, if it occurs after 27th day, that is 28th day or more, it is called recurrent, means reduced and again reappeared. If it occurs in 27th day or less, within a short period of time, we will say it as chronic ENL, means the same episode is not reduced. If it reduces only, it can reappear and we can call it as recurrent. The same episode is continuing if treatment free period is less than 27 days. It is chronic ENL. Acute ENL, lasting less than 24 weeks, responding well to treatment, and slowly we can withdraw the treatment without any recurrence. But in chronic cases, lasting 24 weeks or more, requiring treatment either continuously or treatment free period is just 27 days or less. If treatment free period is more than 27 days, it means it has completely reduced, and if it occurs more than 27 days, that is 28 days or more, it is recurrent. Treatment is required continuously in chronic cases, means if we reduce, again flare-ups may come. That means in chronic cases there is risk of developing steroid dependency, which is nothing but tapering steroids results in flares. Steroid non-responders means patients those who are requiring higher doses of steroid with each episode requiring higher dosage than the previous one, means they are steroid non-responders. In all these cases, we have to consider alternative drug for steroid. At the end, we will see difference between ENL and relapse. Timing, less than 2 years of starting treatment, ENL can occur. means the antigens of the lepra bacilli is ready to produce reaction, nothing but ENL. Here in relapse, I already clearly explained you, lepra bacilli will be in dormancy for some time and then they will become metabolically active and then replicate again leprosy. Reappearance of leprosy after completion of treatment at any time is called relapse. Usually it takes years of time, usually more than 2 years of time. ENL less than 2 years of starting the treatment, but can occur until 7 to 8 years after treatment also. Occurs in LL, rarely BL. Here it occurs in BB, BL, LL, rarely in tuberculoid pole, borderline tuberculoid. Onset is sudden and rapid. Resolution is also very fast, only subside in 2 to 3 days. I already told you, evanescent. ENL is evanescent. Here it is insidious or gradual. Here gradually progresses, it won't resolve. Soft lesions will become firm, pink lesions will become skin colored, infiltration will involve the entire thickness of the skin and it will spread, it won't reduce until we give multi-drug therapy. Constitutional symptoms are severe in ENL, absent in relapse. Epistaxis. Relapse is nothing but leprosy itself. We will see epistaxis is usually present. Here in reaction usually absent. In slit skin smear mainly we will appreciate fragmented dead bacilli in ENL. BI will be same or reduced compared to previous one. Here BI will be increased. Solid stained bacilli, nothing but we can appreciate live bacilli. Increase in BI of 2 or more units in multibacillary cases. It is the criteria for relapse. I already told in my previous video. Response to steroids will be excellent in ENL. E for ENL, E for excellent response to steroids, improves in days. Here in leprosy, nothing but relapse. It is temporary only if improvement has occurred with steroids. So we'll give first steroids to differentiate between reaction and relapse. We'll give steroids first. If it improves, it is reaction. If it improves temporarily and again reappears, it is relapse. Skin lesions, nothing but nodules will be tender, warm, erythematous, blanchable and superficial. Here lesions will be full thickness of the skin involvement, non-blanchable, non-tender, not warm, pink. Remember my channel name, The Average Derma Doc. Don't forget to share and subscribe. Thank you. Hasta la vista. До свидания.